morning,
Good
everyone.
morning. Good morning. Good morning. So we apologize for a few minutes of the late start. This is Amanda Polly with DVHR, and I'd like to introduce to you Rachel Toast and Virginia Selleck. We are having a minor technical difficulty this morning. I'm having a hard time getting Virginia on here. Rachel.
I'm here. Amanda,
oh,
did you hear me?
Yay!
I've been here. I've been alone. I'm just a tell.
Oh, good. This makes me happy. Rachel, you can hear you can speak to then, yes?
Yes, I can hear Virginia and I can hear you. I'm not sure.
That's fantastic, and I'm hoping that everybody else can hear us too. So today we're going to be talking Washington State housing providers and everybody else who's listening. We're going to be talking about the importance of integrating supportive housing and supported employment together in your agencies and keeping that as part of your book of business. And we have our wonderful, once again, Rachel Toast and Virginia Selleck here to talk about how to do that and how important that is for Washington State and anywhere really. And so what I'm going to do is hand this on over, and let's see, Virginia, is there anything, Rachel, is there anything you need from me aside from? I've gone ahead and handed it over to you, Rachel, for the controls. I'm going to go ahead and monitor questions. So please, everybody, feel free to write questions in the box. Raise your hand if you have specific questions. We'll try to get to you as quickly as we can. We're so very glad that you're here to listen and participate in this today. So go ahead and take it away, ladies, and I'll shut up now. And
okay,
thank you very much
Amanda,
for being here.
Amanda, this is Virginia, and I want to let you and the group know that I am not looking at a computer. Instead, I am looking at the lovely rolling Mississippi River from a hotel room in St. Louis. And so consequently, I cannot see the questions. Rachel is well able to handle the slides, but when there are questions or comments or whatnot, I'm trusting that you two ladies will verbally tell me what they are or tell me to shut up so that I can answer them or whatever it might be that we need to do. So that would be much appreciated. Okay, good.
No problem.
And the way we're going to handle it for those of you out there is, because I can't control the slides, Rachel is. You may hear me say, next slide, and Rachel will certainly do that. We'll be taking turns a little bit with the material that we're going to go over today. We are very glad to have you, and the purpose for today, which is slide 2 for those following along at home, is that we're going to review the evidence-based practices of supported housing and supported employment's shared principles. We believe that these two activities or supports are really the twin pillars of recovery, and in particular that supported housing and supported employment leverage each other's outcomes, that they are an intersecting situation where people live and how people work affects each other, which undoubtedly those of you who are doing the work are certainly aware of this, but we're wanting to let you have a moment to relax a little bit and think through some of these things this morning for a little while, because we know this is important work that you're doing. We're going to have an opportunity in a little bit for Rachel to spend some time getting more detailed, speaking more about the operationalization of these principles, and she will give you an example of some work that she's done. And I'm going to sort of lead us off by speaking about the mutual understanding of supported housing and supported employment as social determinants of health. Some of you may be very familiar with that phrase. All this kind of stuff bears repeating, hopefully, whether or not you're familiar with it or not. Every time you hear, at least in my case, every time I hear somebody speak about some things that I think I really do know, sometimes I hear something new. I was just telling Rachel before this that I am at this conference and just heard a woman speak, Becky Margoliti, I think her name is, who she's talking about leadership and has a phrase that has resonated with me since I heard her say it at another conference about 3 months ago or 8 months ago, which is that when we're thinking about our goals and our objectives and what it is that we're doing in our work, that we should frame our thinking in as much as that some is not a number and soon is not a time. we will be speaking, both of us, Rachel and I, in a way that we hope will enhance your sense of urgency about the work you are doing, because the work you are doing is critical to the health and well-being of people, and we really want to help you tap into the value of what you do. It is more than many others may realize, and in fact, and I don't wish to be overly dramatic, but it's dramatic that these social determinants of health really do affect life and death for people. We know that persons with serious mental illness die 10 to 25 years younger than the general population of modifiable health conditions. By modifiable health conditions, I'm speaking of things like cardiovascular problems, diabetes, obesity. Well, obesity is actually a cause, not an effect. Tobacco use, various things of that nature are modifiable, and the persons that we jointly are working with in housing and employment with people who have serious and persistent behavioral health conditions are really at risk in serious ways. And things like employment and housing are huge impacts on those. So we want you to think about how your work in collaborating together may affect those social determinants. So I'm on slide 3 now, and I'm just going to kind of mention some of these social determinants and ask you to, in your quiet way where you are listening to this or watching this, think about what you know about them. So social status is a social determinant. People who are so-called at the country club, have a different way of being looked at the world than many others who have experienced poverty and so forth, which poverty, of course, is an intervening variable in many of these other social determinants. Childhood experiences. I'm sure that many of you are aware of the ACEs study that looked at childhood experiences of a negative nature and how they affected people many years later in their life. That things that happen as children can have serious effects later. This is not to say that people are doomed or that they cannot overcome these bad experiences that they may have had as a youth, but that our work, part of our work is to help people develop resilience and move beyond some of those bad childhood experiences, but it's important to recognize that they happen. Education and literacy are important for both employment and housing. People that can't read have a great deal of difficulty on lots of jobs, and all the way to things like reading a street sign to know how to get to their job, or literacy in working with a landlord to understand what their responsibilities are, as a tenant. Nutrition is key, and of course is intervening variable having to do with poverty. But nutrition, not just having good nutrition, but being aware of what nutrition is and how it affects a person's overall mood and health. The importance, and people who are living in what we call food deserts, who may only have access to fast food or corner store type prepared food and aren't really aware of what the difference can be, in a person's life by eating healthily. And of course, that takes resources. Buying an apple can be more expensive, or maybe not just an apple, but buying an apple, broccoli, and lettuce, you add that up and it's costing way more than the dollar menu at McDonald's. Employment, of course, is what I believe to be a linchpin along with housing. Employment affects things like poverty, affects things like your physical environment, because your income can help you afford to live in better places. And you can see those three, employment, housing, and income, are all really yoked together in a sense that people who are living in unfortunate either homelessness or in very substandard housing, it is very difficult to manage your employment or to get employment. And consequently, if being homeless, people, we do know, of course, that many people are employed who are homeless, but it's not easy to get yourself ready to go to work whenever you don't have those resources. Access to health care is key. Social support networks, and the bottom two there. And of course, all these things interact with each other, but we want to sensitize you to them all as really within your scope of, or sphere of influence and scope of practice. So things such as gender and exposure to sexism, culture, race, ethnicity, and exposure to racism, those kind of things down there, I would also suggest that they really dovetail with trauma and the consequences of trauma that people may experience by having been exposed to racism and sexism creates trauma, and those consequences reverberate through the others. So we really hope that you'll sort of keep those in your mind. You're not just getting somebody a job. You're not just getting somebody a house. You are actually affecting in a meaningful way their health. I'm hearing, is somebody trying to talk to me there? I'm hearing a little interference. Okay. So I'm going to keep going, and whoever is in charge there, if there's noises that can be silenced, I'm sure you will do it if somebody needs to mute themselves. Or if you want to talk to me, just tell me to be quiet and listen. So slide 4 sort of outlines some of the modifiable risk factors that we know about that are intersecting or affected by housing and employment. When you think about both of those, depending on what lens you look at it through, and hopefully part of our work here today is to help you think about both. If you may be a person who is working both in housing and employment, or you may be working on one particular track or the other, but you are intersecting with colleagues who are working on the other thing. Think about how smoking, for example, is a modifiable risk factor, and how employment may affect that. If you're going to work every day, most everybody cannot smoke on the job. Some housing situations now are asking people not to smoke in the buildings. Those things are health supporting. Weight and inactivity are both affected by not having a place to go or a thing to do. That having a work setting keeps people moving around. The lack of access to care is influenced by poverty and by location. So when you're helping someone get housing, thinking about where that housing is contiguous to the kinds of physical health and wellness care that they may be needing. There's many factors that we know you have to, consider. Social isolation, vulnerability, and violence are all modifiable risk factors, but they are all connected to poverty, which is all connected to housing and employment. So it is a web of support that we're trying to build for people that lifts them above some of these risk factors. Medication and polypharmacy is another one, and anybody that's working in housing and employment, I'm sure you are very sensitive to what the medications are people are taking, and whether or not they may be seeing more than one doctor, whether or not the doctors are talking to each other, whether or not people are shopping for medications perhaps to manage symptoms that are very unremitting, and they may need help in the sense of figuring out how that polypharmacy is affecting the other risk factors that they are dealing with. And of course, unemployment and poverty. Unemployment is certainly modifiable, and in particular, at these times, the unemployment rate is very low for the country as a whole, lower than it's been in a long time. And in Washington State in particular, it's very low. But even in Washington, we know there is variation. I was just out there about a month ago looking at having a presentation around rural job development. I don't know if any of you were there, but we looked at the counties in your state and can see that while your overall rate is very low, there's a county or two that's up around 9 or 10%. So those things still are prevalent and have to be paid attention to. The separate silos of care is one that you guys really have some control over, because you are all working in whatever silo you're in, and part of your job is to break down those silo walls and work collaboratively to help people around those things. Slide 5 is a succinct way of describing something about employment. But before I go to that, I just want to say that I think those of you that are doing supported housing, I don't know if you would agree with this, but in my experience with doing supported housing or housing in general, when you speak to the general public or you speak to other health professionals, it's kind of intuitive to them that being homeless is a bad thing or being poorly housed. I think people you don't have to argue a whole lot about that. It's very detrimental to people not to be housed appropriately. Employment's another thing. Employment is often thought of as a boutique service, and people have to just be well enough. You have to get well first, in order to go to work. But we do have this study, or this review of studies that Maroney and Hoff did, showing that Studies going back as far as 1938 determined that unemployment is the cause of, rather than the result of, increased mental distress, social disconnection, increased substance use, and physical illness. The point being here that for regular populations who are not challenged by behavioral health disorders, when they become unemployed due to economic circumstances or whatever might happen, they are much more likely to begin to develop these symptoms and syndromes of mental distress, social disconnection, domestic violence. Bad things happen to people in this culture when they are unemployed, and we know that very large numbers of the persons we serve are in the behavioral health system are unemployed. There are some principles in common, many principles in common. This is now slide 6. And if you're looking at it, you can see that we've got the concept down the middle, and on the left, we're looking at how IPS, supported employment, actualizes that concept, and on the right, the supported housing one. Both share those underpinnings, but I also want to point out, and I know you know, that each of these subjects, supported employment or supported housing, have some specialized knowledge as well. It is not, and you guys know that, because it's not good enough just to think, okay, I'm going to help somebody get a job or help somebody get housing. The housing people have to know all sorts of intricate details about what subsidies and about how to deal with landlords, various intricacies about neighborhoods. It's specialized knowledge. On the IPS side, the supported employment side, people have to know things about benefits planning and what is the local employment market, things of that sort. So what we are not saying that your jobs are the same. What we are saying is that the conceptual underpinning is so shared that that it can help you feel, remind yourselves really that you're working in partnership across these concepts. So client preferences are at the center of both of these practices. Careful career profile based on stated interest is what we do with supported employment. And in housing, people's personal preferences are key. The zero exclusion, again, you find housing to fit the person. You don't just plug the person into the housing. And you begin to think around harm reduction. That is to say, just with employment, same with employment, we don't tell people, well, you have to be not using any substances and you have to have demonstrated XYZ thing before we're going to let you have a job or before we're going to let you be housed. That we work with people where they are, that we start with the person and we wrap our services around them. I already mentioned the sense of urgency, but I want to reiterate that. It's a difficult concept to keep going. It's hard to keep lively every day, but that sense of urgency really helps keep people safe, and it helps keep them moving forward. I mean, your sense of urgency helps them believe that it really matters, and it's easier to join with someone whenever they sense your enthusiasm and your urgency. The integration with behavioral health is key on both sides. I'm sure that does not bear too much explanation, but you both, all of you, anybody, whichever side you're working on or both, know that the coordination with the behavioral health system is key and not easy to do. Benefits planning, again, a central factor to both of your work, and community integration we are talking about here. We're talking about moving people into integrated community settings, both in employment and in housing. I'm now going to turn it over to Rachel, who's going to give us some more information on slide 7.
Great. Thank you so much, Virginia. Really excited to get to speak with you all today. So, we are going to talk at length about the integration and what that looks like, but we also just wanted to make sure that we're all working from the same definition of what we mean by evidence-based permanent supportive housing. And so we wanted to review the principles of that. And the next slide, we'll talk about the principles of evidence-based supported employment, just so that we're all on the same page. So for PSH, or the principles, we're providing individually tailored and flexible supportive services to folks who are enrolled and being served in supportive housing. And those services need to be available 24 hours a day, 7 days a week, and are not a condition of ongoing tenancy. So it doesn't, what we're saying is services need to be available for folks after hours, on weekends, when crises arise, but we're not requiring people to participate in those services in order to qualify for their housing voucher or the supportive housing program. Really, the art is that you are a supportive housing case manager who is so charming and skilled that people want to answer your calls or want to open the door for you. And that's how you're able to provide folks with services that they need. Individuals served can accept or refuse treatment or other services, but your job is to continue to offer support and use flexible engagement strategies. There are all kinds of innovative practices about how you can help people get to the point of being able to accept and engage in treatment. Sometimes it's taking somebody out for coffee or shooting hoops outside, whatever, being really flexible and creative about your engagement strategies with folks. The type, location, and intensity and frequency of services adjust to meet your individual client's needs. Housing is affordable, with tenants paying no more than 30% of their income for rent and utilities. That's what makes it affordable housing. Leases are held by the tenants without limits on length of stay and at a location of their choice, so that people are securing housing in, ideally, the neighborhood of their choice, the building of their choice. Now, we certainly appreciate that there is a huge gap in terms of the availability of affordable housing. So we understand it's difficult sometimes to help people find the housing in the exact location that they want. But when possible, we really want to promote folks living in the place of their choice. And then, as we highlighted earlier and we'll talk about later, there's ongoing collaboration between service providers, property managers, and tenants to preserve tenancy and to resolve crisis situations that may arise and to promote recovery. All right, going on to the next slide. So now talking about evidence-based supported employment principles, we're talking about, can folks hear me okay? I'm hearing. Yep, okay. Rapid job search. So participants interview for jobs within 30 days of their enrollment into the supported employment program. This is a sort of feature of IPS, or the supported employment model, is that we're helping people interview for jobs very quickly. There's an attention to interest, so clients are supported to work in fields that are of interest to them. People are assisted in finding competitive employment, so real jobs that anyone can compete for and that pay full wages. That there's systematic job development, so the supported employment specialists are systematically visiting with employers based on their program participants' interests to learn about different businesses' needs and their hiring preferences. In supported employment programming, there is a zero exclusion sort of principle where eligibility for supported employment is based on clients' desire to work, regardless of their history of illness or substance use, or even history of criminal justice involvement. And then again, this service integration. So supported employment really only works if the supported employment specialist is working in partnership with behavioral health and housing providers to coordinate care. It's very difficult to be successful at assisting somebody to find and keep a job if their behavioral health provider or housing provider doesn't know what's going on, or they're not all on the same page, they're not in agreement. So it's very important to coordinate that. It's important to provide benefits counseling so that support employment specialists and clients review the impact of employment earnings on SSI or SSDI or SNAP or TANF or other benefits and entitlements. And then finally, it's important to provide long-term individualized support so that clients are receiving ongoing support to assist with their successful maintenance of jobs, accommodations, departures, so that if a person's in a position that isn't a good fit for them, that you can support them in exiting that position in a responsible way that doesn't interfere with future references or burn out the relationship that your program may have with an employer. And it's also important to help promote folks in their career advancements and be thinking about what's next. All right. On to this next slide. Having a little bit of difficulty getting
I think this is back to me, I believe, and we're going to be talking a little bit about core competencies for staff and clinicians. I think it's slide 9, Rachel, if that helps.
Yep, I've got it up now. Thanks.
Okay. Rachel spoke about being charming, and I want to reiterate that she is charming, certainly, and that they probably never taught any of us how to be charming in college or school. But in fact, those personal characteristics, like being charming and others, are things that are really underpinnings of core competency for us. Personal temperament is a factor in how well we do any particular job, and choosing what kind of a job you're in, is driven partly by your likes and dislikes. However, I also would point out that as we mature in our work lives, we begin to exercise those muscles in ourselves that make us be better workers. And if we're honest with ourselves, we sometimes have to step out of our own rigidity and think about what we have to change in order to keep moving forward with all the stuff that we have just spoken about in terms of what needs to be done with housing and employment. But there are certain core competencies that if you have these, or if you can develop them with your teammates, it will help smooth the path. Some of this is knowledge-based, and some of it is temperament-based and attitude. So we've got a few different things operating here. The trauma-informed practices is one that certainly requires training and awareness. This is a new concept in the last, maybe 10 years or something, that we've been really speaking about trauma. I mentioned the ACEs study before, but in general, having people really understand the biophysical consequences to humans, and animals too, but humans in particular, about trauma and how it reverberates down through our lives and how it causes people to behave. So we have to think about the persons that we serve, the trauma that they may have had before coming to our services, the trauma that they may be still having, and the trauma that we may be re-traumatizing, maybe not us in particular, but that things may occur that re-traumatize people as they move through these goals of housing and employment. When you're picking jobs or houses for people, being sensitive to what their trauma history might be like, which would have to do with the appropriate setting for them. And it is a sensitive matter, but it is a core competency. And no doubt your agencies are working along those lines. And if they aren't, that's an area that you might request help and training in. The attitude part about having a strengths orientation, being solution focused and person centered, all of those things are essential. Building rapport with somebody so that they will let you in the apartment when you know they're needing help and they're maybe doing things that are putting them at risk of losing their housing or putting them at risk of physical difficulties, having that rapport so that people will let you in the door and that they'll want to talk to you so that you can help gently steer people to the more healthier path. Being dependable is one that cannot be overlooked. Many of the people we serve have experienced tremendous amount of undependability in their lives. The system is not very dependable, for example. Lots of different things may have happened to people that make them untrusting. So trying to be as clear as you can be with this I can do, this I can't do, I'm coming Tuesday, and if I'm not coming Tuesday, I'll call you to tell you why not. That kind of basic stuff really matters. All of you are having to work in navigating other systems and coordinating with many other partners. There's a list of them there. If you're looking at the slides, in case you can't see them, it's hospitals, health clinics, parole, landlords, Social Security, TANF, folk rehab, family, child welfare. The list just goes on and on. Sometimes we have the unfortunate tendency when we are being very frustrated by having to work with those other entities to say to yourself, those other people are just bureaucrats. My agency is the only one that really cares about the client. You get very frustrated and you think that those other people are just being oppositional and they are not, that they are purposefully or are uncaringly not working with you. It is a core competency to be able to put yourself in a place where you can have sympathy and empathy for your coworkers who are singularly, like yourself, having to deal with their own rules, policies, supervisors, time frames. The computer system just changed and no one trained me, et cetera, and so on. So to hold that in the back of your head, that these people are suffering just like you are in whatever bureaucracy you're in, trying to move the system to work on behalf of the persons you're serving. It also requires us to be willing to get out of our own box. And sometimes you have to not just do your own box, you have to be willing to work the boundaries, and sometimes that can feel risky because you're talking to people's systems that you don't thoroughly understand. But when you enter it into a spirit of inquiry, people are usually more than willing to explain to you what their problems are about why they couldn't do the thing they said they were going to do. The ability to break tasks and to clearly define steps for clients and sometimes partners is very important. The whole issue around referral across these different systems is an example. We were doing some work in Washington out there with working with your job source, helping the behavioral health side understand how to refer people into job source and vice versa. Some people can just walk right into the job source and get some help, whereas to walk right into the behavioral health system sometimes requires certain steps and whether or not people have insurance and so forth. So being able to systematically describe what those steps are for people and to understand others. Having that enthusiasm to try to do whatever it takes and to make a situational on-the-spot assessment resolving crisis that threaten people's housing and employment is very valuable. To be able to try to let yourself learn how to calm yourself and think on your feet when a crisis occurs, because crises are always going to occur. So the goal of not numbing yourself to be rolling your eyes and going, here we go again, this is happening all the time, to remembering that for this particular person, you must act with that sense of urgency. The one that everyone hates the most usually, although I shouldn't really say that because some people really do enjoy being orderly. My daughter is an extremely orderly person. I suspect that Rachel is very orderly too and probably keeping records. It's not just a thing that we have to do to get paid, keeping timely, detailed, and accurate records of your encounters. It is much more important than that. It does, of course, allow us to get paid through whatever sources are paying us. Our employers and our funders need to know, what we have done that warrants the reimbursement. But think about it as you're really helping your coworkers presently, because almost in all cases we're working in some sort of a team situation, and people will need to know what you have done with this particular person or how the person you're working with is. And also the people that come after you. I hear all the time about, people come and go. There's high turnover in the human services. And, our clients go through a lot to tell you their history and go through their experiences and remind you of what went on. No one wants to have to tell their story over and over again. It is very important to help the client know that the system is paying attention to them. It wasn't just Joe that was my worker. It's the whole team that cares about me. So keeping those records up to date and keeping it real, and it helps you to coordinate the care, and you're documenting your efficiency. I mentioned again before that woman that I just got through hearing speak about goal-oriented stuff, and soon is not a time, and some is not a number. That's really critical when you are keeping your records, to know when something is supposed to happen. How are we going to know if we succeeded with this person? What steps and progress and timelines are we doing? It helps the person served to get a sense of movement, that we're really serious about moving forward with supported housing and supported employment, if they know that you're keeping track, and that you are that they are seeing that you're documenting, and hopefully you're doing collaborative documentation with people so that they are a participant in their own records. Now, the bottom of this slide says, do you have other ideas and what's your experiences? I would ask you to put that in the chat box or be thinking about it. And whenever Rachel has completed some of the conversation she's going to have with you now, we can certainly return to those ideas. And Rachel, please give us some ideas about successful service integration.
Great. Thank you, Virginia. I love listening to you every time. It just really energizes me. I wanted to talk next about a real example of an organization where there was integration between supportive housing and supported employment, so that folks have a sense of sort of, the amount of work that needs to go into that, the time it can take, but then the real successes as a result. So in Portland, I previously worked for an affordable housing and healthcare organization that was founded in 1979. And in 2007, the chief operating officer authorized the senior director to begin the adoption of the IPS model. So this was an ending homelessness, healthcare, affordable housing organization where there had not yet been supported employment. So you can see that, that started in 2007, and by 2011, that organization secured a fidelity score of 116. I think the highest rate that you can earn in a fidelity review for IPS is, I think it's 120. So this was the program that achieved the highest fidelity score in the state, with 18 other sites having been ranked. And then in 2014, this program was recognized as one of 11 exemplary programs by the United States Interagency Council on Homelessness, HUD, and Department of Labor at a national summit on the integration of supported employment and supported housing. And in 2017, this program, the highest percentage of people who were employed, it reached 70% out of the 34 sites in the state at that point that had adopted IPS. That program that achieved this ranking had 22 different employment specialists, and 790 individuals were employed in that calendar year through this program. So let's talk about sort of the transition and what was involved. So I'll tell you that there was quite a bit of culture shock for the organization and the people who had worked within that organization for many years. The adoption of IPS was, there were a lot of folks who were really skeptical about it, felt threatened by it. Even seasoned and highly respected leaders in the organization who had been doing really important, significant work in the community for many years were skeptical. There were concerns expressed by the agency's medical director, psychiatric director, mental health director, the director of substance use and treatment services, and even the employment center director. So I think some of the objections or concerns raised were that the people that we served at that organization were too sick to work, that people who were involved in outpatient treatment really needed to focus on their treatment. We should not be distracting them with talking about employment that was going to cause them to relapse, that we weren't going to be able to find employers who were going to hire these people. A lot of the individuals served through the agency had histories of felony, criminal justice involvement. And the discussion of implementing the IPS supported employment model was really met with a lot of sideways stares and disbelief from both leadership and frontline staff alike. But thankfully, there was full-on commitment from the CEO and the chief operating officer. I have confidence that had those two folks not been really committed to the adoption of IPS, that the organization would not be where it is today. Okay, so now we're going to talk about the steps that agency went through to overcome the sort of macro level resistance. So we provided presentations on the IPS model that documented, the efficacy, research studies. All of this was provided to the leadership team and the board of directors. Presentations were also made to program directors and managers. We instituted sort of an adoption timeline that management was accountable to, so rolling out the programming to target the supported housing building as a pilot before moving into large-scale agency-wide adoption. So we first started using this supported employment program in a building where there were 100 units of transitional housing for people who had self-selected to enter into alcohol and drug treatment. And these were folks who were typically coming out of the city's detox center into this transitional housing. They were previously homeless, and we started to pilot supported employment with that population of individuals. We provided rigorous IPS training to both the supported employment, the new supported employment specialists, but also to the supported housing staff, because the expectation was they were going to be working in collaboration and coordination from the get-go. We began using the fidelity scale to monitor stage of implementation immediately and to really convey the intention that we were going to adhere to this full model with frontline staff as well as management. And then we participated in an independent fidelity review annually that was administered by the Oregon Supported Employment Center for Excellence, and then promoted success stories through social media and pursued partnerships with the Department of Voc Rehab, with the Department of Human Services, particularly the TANF program, and then the Workforce Investment Opportunity Act funded systems. So these were all shifts that we were making as an organization to really put out there that employment was front and center, that we knew that the folks that were being served and supported housing, we wanted to promote the true belief in people's potential for recovery and for integration back into the community. Now I'm going to talk a little bit more about some of the micro level interventions that we made as an agency. So the hiring process for supported employment specialists and new housing case managers included a panel of interview questions that really helped us sort of identify who was a believer, people who believed that people could work when provided the right kinds of supports, and helped us screen out people who were skeptical of that. There were team and individual supervisions that celebrated people who were able to adapt and come up with creative ways of engaging clients and other staff. And at the same time, the team supervisors were able to help coach out staff who were sort of perhaps had transitioned into this program under the old model but couldn't really adapt. Program successes were sent out to those targeted for expansion. So the outpatient treatment counselors and the assertive community treatment team, the psychosocial rehabilitation day center staff and managers were all kept abreast of what was happening with the program and really featuring some of the success stories of people who were finding work and who were, identifying, ways in which that employment experience was improving their quality of life, helping them reunite with family and friends, individuals who, as a result of their employment, were able to perhaps move into their own housing out in the community. So that kind of thing, those kinds of successes were disseminated out. And then we were also really intentional about how we operationalized what integrated and coordinated services looked like. We really had to define that for ourselves and for our staff. And so these were some of the characteristics of what it looked like and what it meant. It meant that supported housing case managers and supported employment specialists would meet with program participants at intake to establish service plans with measurable actions and outcomes. It meant that support employment provider and support housing provider would meet with the program participant as a team every 2 weeks to update their service plans, that they would work together to meet, to brainstorm on a monthly basis about obstacles to successful attainment of participants' goals, that the supported housing, supported employment, and mental health or SUD provider would meet monthly with the participant to review their service plan and assure that everyone was working together. And participants requested to sign a release of information so that coordination could happen. And then also the agency's quality management IT department was engaged in reviewing programmatic outcomes and measuring the degree of care coordination so that improvements could be made. And that agency had the advantage of an electronic health record, which included enrollment into supported employment or supported housing, so that clinical teams were also included in the coordination of services. So I'm going to turn this back over to Virginia. I know that we're close to, we've got 10 more minutes, but Virginia, you want to talk about sort of the challenges that have emerged in Washington State?
Well, what I want to do really is hope that there's people in the chat box out there that want to participate in talking about those challenges or indicating if they're having them or not. We did this webinar once before, a few months back, and some of the things that was sort of anecdotal. Some of the questions that were coming up were whether or not employment was on the minds of the supported housing providers, and whether or not, the meat of this really is what Rachel just went through in that last slide about how would you really operationalize how to work collaboratively. And so we would like to hear from you if you have comments or questions or, you know, dilemmas that you want us or your colleagues on this webinar to talk about. We heard that there may have been some need for growth in the understanding of what zero exclusion means as we went over that, the idea that you know, you start where the person is and that we don't expect a lot of preliminary work on the part of people in order to be quote unquote eligible for, you know, supported housing and supported employment. And what we also heard about a little bit was the importance of communication in interagency program work, which Rachel outlined a minute ago. So I guess we would like to hear from you. And Amanda, you are there, I think, and can see the chat box, which I cannot. So can anybody tell us if there's anything in there?
So there's no questions in the chat box yet, but I did send a message to the audience and ask, does anyone have any questions or comments for our presenters? We're happy to take any questions or comments that we have.
Can they speak, or do they have to do it in the box?
If we unmute everybody, it will be chaos, utter and complete anarchy. So, it would be best if everybody, it would just be a lot of reverb that we would get back. So it would be it would be better if people went ahead and typed their questions. Or if you raised a hand, we might be able to unmute you individually. So that's a possibility as well. So let's see if you're willing to raise a hand. I'm looking right now through the attendee list. Oh, I see Cynthia Eichner. Cynthia, I'm going to unmute you. So if your phone is personally muted, you might want to go ahead and you can speak now, Cynthia. Or you should be able to. Can somebody unmute her? I keep trying to.
Well, and then Cynthia perhaps could type what she wants to say if she can't talk. And we know sometimes there's like a tape delay on that chat box. Usually, you know, you're typing away and you can see that somebody's typing, but we can't see what they're typing. So we are patient. If you want to type, we will all do a small meditation exercise while you type.
Okay, just one second. I'm going to try one more time, Cynthia, to unmute you for, let's see. We're going to, and then one more time. Let's see here. Attendee is self-muted and muted by an organizer. Okay, so Cynthia, try to unmute yourself. Okay. Yay. Cynthia, go ahead and ask your question.
Hi, how are you?
Good.
I was wondering if you could perhaps identify the organization in Portland that you were profiling, or is that something that you can't share? We are a supportive housing organization in Snohomish County in Washington State, and I would be curious to know who your organization was that you were profiling in Portland.
Yeah, I think that that they would be comfortable with that. That was Central City Concern.
Thank you.
Is that all you have for us, Cynthia, or am I okay to remute you?
Yeah, you are fine to unmute me. Thank you.
Okay, no problem. Thank you. Anybody else, if you want to throw a hand up, we can pull you off of mute as well. Okay, it looks like we have some questions. So let's see here. All right, so Dina, and I apologize, Dina, or Dinah, however we say your name, and I'm going to go for Geisler. It could be Giesler, so please don't hate me. Are there agencies that have had success hiring staff that serve both supportive housing and supportive employment?
So let me ask for,
No, go ahead, please, by all means.
Okay, yeah, I think I just need a clarification. I'm not sure if the question is, are there agencies that employ staff who do both the supportive housing and supported employment, like one person? Or is the question, are there agencies that have successfully hired supported employment specialists and supportive housing case managers?
Right. That's a really good question. Let me see.
So maybe I'll answer both just to save time. So I think, I think that it's important, I have seen programs across the country where they have tried to merge the two. So a housing case manager who is also tasked with doing supported employment. I think that it's important to have staff who are dedicated to each of those different elements of service, that you not have one staff person trying to do both. Because invariably what happens is that if there is a mental health crisis or a housing crisis, is that the supported employment services kind of fall to the side as less of a priority. Whereas when you have a supported employment specialist who is tasked solely with that piece of the service, that remains equal to every other, need that a client has. So Virginia, I don't know if you would echo that or if there's something more you would want to think about.
I would just amplify that by saying that, first of all, yes, there's many agencies that do both of those services, but and I don't mean simultaneously one person doing both, but rather that there will be a housing specialist and employment specialist working together there. And if you were doing fidelity supported employment, IPS, those of you that are aware of that, you'll know that it would not be in keeping with the fidelity to have that person also be doing housing. However, I would comment that there are nuances and difficulties both in your own agency. You could be all working as one big agency and have a housing part and a employment part, and you still have to go through the kinds of steps that Rachel outlined there at the end about the operationalizing at the micro level, how those parts are going to collaborate with each other. And then there's also the supporting of each other. I worked with some places in Illinois for a while who had maybe group housing or supported housing, various kinds of housing, and those workers needed to be holding in their head that employment still was going to be a goal and was important, and helping to leverage thinking about employment while they were busy doing housing. So when you're trying to find somebody a place to live, you might say to them, let's think about where your work might be geographically anywhere near where this housing is. You have to figure out the staging of, are we going to help somebody with housing first? Are we going to help them with employment first? And how do those two things geographically or programmatically need to be staged? So I guess I would put it back on that, thinking about when you got the client at the center, what's the most important thing to them, and how might choices made in one affect your work in the other.
So Dina, thank you very much, both of you, Rachel and Virginia. Dina did verify that what she meant was one person who does both SH and SE with the same client, and you guys did answer that, and I agree with you. As far as fidelity goes, and if we are speaking towards our IPS and our PSH principles, we do like to see, Dina, we do like to see that we have our SH and SE personnel staying in their own lanes and doing as much as possible, and so that they can focus on their primary tasks with their participants. It really does enrich services. And so, yeah, it's sometimes it's the better way to move forward. Another question came through from, let's see, Michelle Mason. I work with level 2 and 3 sex offenders. Finding work is hard, but housing has been almost impossible for income-based housing. Any suggestions?
Rachel, you want to talk about the housing in that respect?
Yeah, that I really, I really appreciate that you're doing this work with that population. It is challenging in every part of the country to find housing for folks with sex offenses. I know in Portland that the county actually funds some transitional housing for registered sex offenders with services, and then dedicate housing specialists who are working to help those folks find housing in the community. I don't know in your community or the program that you're working in whether you all have any of those available resources. It is challenging. I wish I could offer you more in the way of sort of solutions as to how to assist folks with those backgrounds in finding housing in the community. I think short of housing agency, setting aside housing, subsidized housing that is specifically targeted to that population, it's definitely a challenge.
All right. So let's see. Our next question is from Christopher Clifford, and he says, it's tough knowing that when we do our staffing with therapists, that it does not count as clinical meetings for the fidelity review, thus not giving us credit for the work we do. Okay, so not a question, but more of a statement. So one more time, I'm going to read out one more time. So it's tough knowing that when we do our staffing with therapists, that it does not count as a clinical meetings for the fidelity review, thus not giving us credit for the work we do. This must be for employment. Is that?
And if it is,
okay.
it doesn't make a whole lot of sense to me. Maybe I'm misunderstanding, or maybe I'm off the beam here, but I thought that that basically clinical integration, one of the hallmarks of it is for you, the employment specialist, if you are indeed an employment specialist, to be meeting with the clinical team. That's the essence of clinical integration. So I'm kind of not getting why that wouldn't be quote unquote counted. So I don't know what to say about that. I think that it is extremely important and critical, in fact.
I know that in supportive housing with PSH and SAMHSA, that having clinical meetings, even if it's interstaff, counts towards fidelity. So I'm unsure. I'm unsure about that. Christopher, why don't you? I'm going to be sending up a follow-up email to everybody who registered. Christopher, I would love for you to email me back so that I can get you in touch with either Lisa Bennett Perry or Dawn Miller for some more information on that. Okay. And so you'll see an email from me either today or tomorrow, probably this afternoon, with a follow-up email with some more information and the PDF for everything with this. Please just give me, send me a reply, and then I'll just do a quick introduction to Lisa Bennett Perry and Dawn Miller, depending on where you're from, and we'll figure out what this wrinkle is and see if we can get it ironed out for you. Okay. So I think, let me just double check. I think that might actually be the last question so far. Does anybody else have any more questions or statements that they'd like to make? Because we have another 25 minutes, and we can give you 25 minutes back of your life, or we can actually answer some more questions and chat with you some more. Virginia, Rachel, do you guys have any? Do you have anything else that you'd like to add before we run away here?
Well, a problem for us, this is Virginia, is always on these webinars or any time when we're not in the room with people and can, go around the room and say, okay, tell us where your place is in the organization and all that, is that, we're giving sort of an overview here. And I think Rachel did a great job talking about the overarching macro issues as well as the micro. So I think what I would suggest to people is, in your quiet moments, kind of go back to those and think about where you yourself fit in those. Are you a micro person? Are you a macro person? Where is your sphere of influence in your own agency? Sometimes if you are what we used to call a line worker or a direct service worker, you sometimes feel like you don't maybe have as much influence on leadership, or if you are a leader, maybe you need to think about how up that leadership goes. The notion of recognizing that everyone has influence and in your sphere, and to think about what you yourself can be doing to enhance the integration of these two practices. And like we talked about a minute ago, we talked about the doing of it in your own agency, having a housing specialist and an employment specialist in the same agency. But of course, we know for sure that you are tasked also with, if you are a supported employment provider, working with a housing provider not in your agency, and vice versa. And so, you know, it's bad enough to have to reach across within your own agency, but having to do it across town, you know, to another agency also is challenging. And so some of those challenges are geographic and time-based and whatever. So it might be good for you to have a few moments in one of your team meetings at some point to kind of outline where have the rubs been and who has the influence necessary to try to take some of those steps that Rachel identified in the macro and micro levels, if you are encountering difficulties. And noticing if you're an agency that, you know, provides both or just one or the other, and how your outcomes are looking with respect to that. So I would just offer that as a follow-up activity that folks might want to do.
Yeah, and then I think additionally, or maybe as an add-on, you know, as you are thinking about that or talking about that as a team, you know that Amanda and Kimberly and Lisa at HCA are all available to be able to help you all think through or strategize, you know, efforts to do more around integration. And integration, it doesn't have to happen within the same agency. You know, you could be working closely to figure out how to do more to integrate your services with your partner mental health provider agency or supportive housing agency. So, you know, they're a resource. They also are able to, you know, if they don't have capacity, can potentially offer TA from one of their TA firms that could provide you all with some individualized planning to work towards better integration.
Amanda, you're here. Do you have is there anything that you have noticed or heard about from your cast of characters that you're working with there about any difficulties in this integration process that you would care to share? Or maybe things are going great. If they are, that's great. Yeah, the integration of that.
Yeah, most certainly. So the majority of our agencies across Washington State actually have integrated supported employment into their supportive housing program or vice versa, and they're doing fantastic. They're finding the ability to, or they're finding that their participants are able to maintain their housing, and they're not having as many higher support needs when it comes to mental health. And so everything is kind, you know, it was like you mentioned earlier, lack of employment causes a lot of physical and mental health issues, as well as lack of housing. And so when you address both of those, everything kind of lowers. The point of foundational community supports is to target our highest utilizers. And so if we're targeting our highest utilizers, and the point behind them being the highest utilizers is because they're unemployed and unhoused, then if we're housing them and we're getting them jobs, and so we're lowering the rate of not only recidivism, and we're keeping them out of jails, we're also keeping them out of hospitalizations, we're keeping them out of the EDs, we're helping to keep them from revisiting those situations. And so we're finding that as long as our clinicians or our case managers or our specialists, be them employment specialists or housing specialists, are maintaining that decent 15 to 20 person caseload, and they're not overwhelmed, they're doing intentional services, and they're actually staying in their lane, then they're able to they're able to give this quality service, which is able to help our participants move forward in their life. And so supportive housing stays in their lane, supported employment stays in their lane, and everything is coming together really well and very smoothly. So it's actually working out well. DBHR offers a massive amount of training and support, and it's all free. So we're here to help as much as possible. So if you are having struggles, please don't hesitate to reach out to DBHR for help and training.
Thank you. That's very, very good.
Thank you.
I
had some good TAs.
Good. Well, yeah. I want to give you guys a quote because I'm sitting here looking at the Mississippi River going by, which is of course, I think of Mark Twain. And he said that change is the handmaiden nature uses to work her miracles with. And all the stuff that we're talking about here has involved change. And so you guys are all change agents. And apparently, from what Amanda just said, you're working miracles. So there you go.
So is there any other questions? Anybody want to toss any other questions or comments or any other wonderful quotes into our chat box? If you want to throw a hand up, like I said, I'm happy to pull you off of mute so that you can speak your mind as much as you like. Don't forget that this is being recorded. that was mostly me.
Well, Amanda, since you did invite other inspirational quotes, this is really one. I think of the people who are attracted to this work. I just feel like and as Virginia said, we're change agents, right? And this is like pretty radical work. And we bring so much heart to it. And I love this quote that actually I got off of my tea bag a few weeks ago, and it's been on my refrigerator. Live righteously and love everyone. And, I think that really speaks to like the kind of souls who are attracted to this work is, I think through our love and our belief in the potential of everyone, we're doing this work because we want to promote the health and well-being of every person. And we know that so many of the people that we work with as a result of trauma or as a result of poverty, as a result of racism, as a result of injustice, that, the work we're doing is we're trying to right those wrongs.
That's right.
That you gave me some chills, Rachel. That felt good.
Oh.
Okay. So it is 9:45. We haven't had any more questions or comments, and I feel really enriched and wonderful. I really appreciate all of the time that you both gave us. Thank you very much. And even though we can't hear the applause from others, thank you. Thank you very much, ladies, for joining us and inspiring everybody to go out there and be change agents and be even better housing and employment specialists than what they already are, which I don't even know how is possible at this point, but we are. And thank you very much for your time and all of your wonderful information.
Thank you.
Thank you. It's wonderful to speak with you all. Have a great day.
Yeah. You guys have a wonderful day too. Be safe, everybody. Take care.
Bye-bye.
Bye-bye.